Good evening. I welcome all the delegates, respected seniors, friends, and viewers at large to this Teleophthalmology Symposium and virtual inauguration program. They say great things are born in tough times. Similarly, the importance of teleophthalmology was further his evaluation was further realized in these tough times of COVID, and the idea of teleophthalmology was born. Teleophthalmology Society of India was born. Access, equity, and equality and cost effectiveness are the key issues facing healthcare. And these challenges require innovative solutions. And I think teleophthalmology can go a long way in filling these gaps. So once again, I welcome you all. Now I would like to invite Dr. Professor BNR Subidhi sir, who is the secretary of the TOSI. He's the ex-head of Department of Ophthalmology, MKCG Medical College, and he has had 36 years of teaching experience to all the undergraduates, postgraduates, nursing students, and ophthalmic assistants. He has published a lot of scientific papers in various national and international journals and presented scientific papers at Singapore, Sydney, and Malaysia. He has more than 300 eye transplantations to his credit and has done a lot of community work in the rural Odisha for the last 35 to 36 years. And presently, he's heading the Ruby Eye Hospital in Odisha. So I once again would like to invite Dr. Subidhi.
Thank you, Dr. Abhishek, for a nice introduction. So, respected President, All India Ophthalmology Society, Professor Mahipal Sachdev, President TSI, Dr. Ashwin Goyal, President Teleophthalmology Society of India, Padma Shri Professor Dr. Natarajan, and Honorary General Secretary of AIOS, Professor Namrata Sharma, our guests from abroad, Professor Hunter and Dr. Helen, and all the office bearers of Teleophthalmology Society of India, and all the viewers, I welcome you all to this launching ceremony of TOSI, the Teleophthalmology Society of India, and the symposium thereafter. Greetings to all. First of all, I must congratulate Padma Shri Professor S. Natarajan to give the shape to our efforts, myself and my colleague, my friend, Dr. Cybersite Patnaik, the idea of forming a society to carry forward the future of teleophthalmology. And with the initiative from Professor Natarajan, colleagues like Dr. Kim Ramaswamy, Dr. Rajiv Mamman, Dr. Sheila John, Dr. T. Senthil, Dr. Ashok Nanda, Dr. Abhishek Sachdeva, Dr. Sandeep Rao, Dr. Kavita Rao. So all these colleagues gave a shape to this organization and today's launching meeting. As already pointed out by Dr. Abhishek Sachdeva, telehealth, a new branch of science, is the discovery of COVID, I say. During COVID times, when people remain indoors because of shutdown and lockdown, the healthcare is shattered. And the people of our country are deprived of the basic healthcare. At this juncture, telehealth or telemedicine came into the rescue of these poor people of our country and gave healthcare to the people. Teleophthalmology, a branch of telemedicine, also did wonders in this period, and it has evolved into an integral clinical tool in the Indian healthcare system. It allowed clinicians to provide quality healthcare out of their clinics to the people in the rural areas having a lot of eye problems during these COVID times, and gave the very good patient satisfaction in this COVID period. As you know, blindness is a major trauma which affects an individual not only physically but also emotionally. It's becoming a global problem. There are approximately 46 million people are blind or visually handicapped all over the world, and out of which a lion's share, about 19 million people are partially blind in India. And out of this 19 million people, 15 million people reside in the rural and hilly areas, and majority or 82% of this population is above the age of 50 years. Basically, a lot of these people who live in the rural and hilly areas are suffering from many preventable eye diseases. I would say preventable eye diseases, and some became blind because of the eye problems, because of inadequate healthcare system, and they did not get proper treatment and timely screening of their eyes, and because of this non-availability of ophthalmists, also lack of infrastructure in these areas. So, moreover, India is one of the country where there are plenty of shortage of doctors, and in India, approximately around 20,000 ophthalmologists with a huge population of 132 crores. It's really difficult to give the eye care to the common man. And most of the ophthalmologists are practicing in the urban areas only. They are not able to reach the rural areas because of so many problems. Additionally, the inadequate infrastructure of the transport, communication, telecommunication, the patients were not able to visit a eye care clinic or eye care hospital to get the proper treatment in time, resulting in the blindness. So at this time, I would say that teleophthalmology had done wonders during the COVID period, and subsequently also it will be evolved into a very good branch to impart eye care delivery to the common man residing in the unserved areas of our country. It's a rapidly developing field. In the past 2 years, it has done a lot of wonders, thanks to the application of clinical medicine by telephone, internet, or other networks for the purpose of consultation and on occasion carrying out examinations or providing medical care to the people of our country. So teleophthalmology definitely will potentially provide healthcare services to the underserved and the remote rural areas where a common doctor or ophthalmologist cannot reach. And many times there are inaccessible areas where the healthcare system cannot reach them. So here comes the both telemedicine and teleophthalmology. So teleophthalmology has the potential to improve ophthalmic care and diagnose many eye diseases in the early stage. For example, diabetic retinopathy. If you do not detect diabetic retinopathy in the early stage, they will become blind. Ultimately, the goal of teleophthalmology is to decrease the global burden of blindness, vision-threatening diseases, and improve the quality of life of the patients with eye diseases worldwide. It will provide high-quality, cost-effective community eye care at the doorsteps of the community. That is our aim of this project. A common man need not become blind because of lack of availability of doctors and the facilities. Society has been formed to look into this aspect with an eye on capturing images, that first stage, transferring images, third, interpretation of these images, and providing eye care at the site of origin. So this is our aim or objective of TOSI. So thus, teleophthalmology can be a very effective model for improving eye care delivery system in India. I'm really thankful to our president and secretary of All India Ophthalmology Society. They are with us. We look forward to get patronage from them. Not only that, also we look forward from TSI. Our president is there. So we look forward to you also, sir, to be a part of this TOSI and guide us how we can move forward. This is the beginning. So this is an infancy. The child is born. Now we have to take care. So once again, I invite all the esteemed guests to this symposium inaugural function of a newly born Teleophthalmology Society of India, shortly called TOSI, to move forward to make India free of preventable blindness. Namaskar, Jai Hind.
Thank you, sir. Thank you. Thanks a lot. Now, I would like to invite Dr. Natarajan. He's a Padam Shri awardee and he has dedicated his life to the field of ophthalmology. And in 2002, he started a free eye clinic in Dharavi and has conducted uh, thousands of free eye camps in various suburbs areas of Mumbai. And in 2013, he was awarded with the Padam Shri Award. So now I kindly invite Dr. Natarajan to kindly tell us about the introduction of Teleophthalmological Society of India, shortly called TOSI.
Thank
Please.
you, Abhishek, and I'm very happy. It was spearheaded by Dr. B.N.R. Subudhi and Dr. Sabyasachi Patnaik, who's the Secretary and Treasurer of the Teleophthalmic Society of India. I'm glad after deliberation we have made a new constitution and also bylaws, and which is being registered in Orissa. And we have Dr. Sendil as Joint Secretary, Dr. Kim from Arvind as the president-elect, and Dr. Rajiv Raman as the vice president. So even though the organization is just starting now, I'm happy that we already have a vision and we are thinking of the future leaders. And we have executive members, Dr. Sheila John from Shankar Nethralaya, Dr. Abhishek Sajdeva from Jammu and Kashmir, Dr. Sandeep Ray from Tripura, Northeast, and Dr. Ashok Nanda from Orissa, and Dr. Kavita Rao from Mumbai. So I just wanted to say that even though Dr. Subudhi mentioned, I think the teleophthalmology is a branch of telemedicine that delivers eye care through digital medical equipment and telecommunication technology. Today, application of teleophthalmology encompasses access to eye specialists to patients in remote areas, ophthalmic disease screening, diagnosis, and monitoring, as well as distant learning. And actually, teleophthalmology was actually started almost in the early 90s, even though fundus cameras were more available in 1980s. But I think currently the mobile applications are available, and we'll be in my talk I'll be informing. And teleophthalmology service can be provided primarily in two ways: synchronously or asynchronously. Synchronous teleophthalmology enables real-time interaction between participants using standard telemedicine technologies, example video conferencing. Synchronous to supervise the removal of corneal foreign bodies and for consultation. An asynchronous teleophthalmology in a store and forward method where data is captured and transmitted for review at a later date. Images of the eye can be captured non-invasively through various methods, generally by a technician or a non-physician healthcare professional. And this is where, thanks to our president, Dr. Maipal Sajdev and Dr. Namrata, who allowed me as an All India Ophthalmic Society president in the last year to take up this project as one of my projects as screening through teleophthalmology to prevent diabetic blindness, called Stop Blindness. In Hindi, we named it Jot Se Jot Jalao, and I'm glad year after year they are asking me to continue as chairman to do this work, and we are making a national network. And now I'm liaising with Shankar Nethralaya Arvind and all the people who are doing teleophthalmology. So the advantage of teleophthalmology is improved patient care, strengthened referral patterns, extend patient care and expertise to remote areas, education of hospital staff, clinicians, and the community, cost effectiveness. I think that's a great thing, and more effective planning and administrative meeting with point and click sharing of content. Using of video conferencing members of the human resources department has helped to resolve emergency staffing issues, and community nurses, ophthalmologists, or optometrists in training can be attended teaching session at the main hospital via live video teleophthalmological feed, thereby enhancing their knowledge and skill. So I think in the future, this will be one of the mode, and I wanted to thank all the members here, and also we welcome whoever is interested. We have made the regular members, and also we have industry members, as well as we also have associate members who are not ophthalmologists, because we wanted only ophthalmologists. This is for a teleophthalmic society, mainly for, we already have a telemedicine society where our president, Dr. We are all members. Most of us are members of the society, and Dr. Kim and Dr. Sheila Jan are executive committee members. So I think with this, we're very happy. And I wanted to mention our Prime Minister has started a program of addressing all the village panchayats, and there are about 6,47,754 villages, and he's able to address them at one go every 6 months. I'm glad our Abhishek Sajdeva has already started in a small way in Jammu in various village panchayats, and I think he does the program in Hindi, and once he invited me, and I wish this Teleophthalmic Society of India will continue, and we will have services which will be free, where already many hospitals are doing, where we are doing in Dharavi, Madurai, and Arvind is doing in entire Tamil Nadu, and Shankarnagar, and many others are all over India, and Sandeep Lakre is doing in Tripura, so many others. So with this, I'm happy to introduce the Teleophthalmic Society of India. I'm glad, thanks to Dr. Subudhi and Dr. Patanaik for choosing me as a founding president. And I hope I will quickly hand over, because too many presidentship I have done. And I think the whole idea is to stimulate, to also involve every member. And we have the youngest group, Dr. Abhishek Sachdeva. He has just started his career in Jammu. So we want young blood to take it over. And we also have a program where anybody is using a smartphone, so we'll be able to use smartphone and do teleophthalmology. With this, I again hand over to Abhishek.
Thank you, sir. Thank you. Thank you for such kind words. Now, I must not waste any further time to invite and welcome Professor Dr. Mahipal Sachdev, the AIOS President, to kindly light the lamp and present the floral bouquet to the TOSI President. Welcome, sir.
Thank you. So are you having some lamp lighting video or snap or something like that?
Yes, sir. Yes, sir.
Yeah.
Kurutvang kalyanam, arogyam kalyanam, arogyam dhana sampadah. Shubham kurutvang kalyanam, arogyam dhana sampadah. Shatru buddhi vinashaya, dipajyotirnamostute. Dipajyotirnamam kalyanam, shubham arogyam kalyanam, arogyam dhana sampadah. Shubham arogyam kalyanam, arogyam dhana sampadah. Shubham kurutvang kalyanam.
Thank you, and congratulations to all the members of the Teleophthalmology Society. Can I have the bouquets for? It's for Dr. Natarajan and Dr. Natarajan.
So I gave, I remember I gave a program to you, and now I'm taking it back. Thank you, Mahipal.
Yeah.
Thank you, sir. Thank you.
On behalf of the entire TOSI, not just me.
Yeah. So I think it's a proud day for all of us, and I think I should congratulate Abhishek, Dr. Subudhi, Natarajan, Dr. Patnaik, Ashok, everybody who has, Dr. Kim, etc., all who have really come forward to form this society. And I think, as was said by Abhishek right in the beginning, in adversity you find an opportunity, and I think the adversity was the COVID, which unfortunately is still continuing, and therein the methodology to communicate with each other came forward in a bigger way. Not that it was not existing earlier, but obviously you tend to focus when you can't meet physically, so you tend to focus on digital ways and means to talk to each other. And in the scientific community, the most important thing in India that happened was that the government was proactive and they legalized telemedicine. Earlier in Mumbai, I think there were 2 doctors who were taken to task by the Mumbai High Court. And I think they were punished to an extent which was really I would say shattering for any individual, that they had given a consult on WhatsApp or something like that, or an SMS without seeing the patient. So I think that instilled fear in everybody's mind. So now there is a legislation that is there by the government, which legalized the use of digital devices for prescribing medicines and for making diagnosis. And there are some restrictions that you shouldn't harm the patient, etc. That's about it. But this is a very big step that came along to have the teleconsultations as a legal format for giving consultations to the patients. And obviously, it was something that was lacking earlier, and it saw an increase in about 700 to 800% in the consultations that were there. So I think this is also been lapped up by ophthalmologists. And what is important in ophthalmology is that we are able to have digital devices. There were a lot of presentations by young ophthalmologists as entrepreneurs also, who came up with small little devices by which we could actually analyze and take pictures of the various parts of the eye and then send these pictures over to a doctor, an ophthalmologist, to kind of have the consult that is there. And then, as was rightly pointed out by Professor Subudhi, there are several sight-threatening or vision-threatening issues which can be taken picture of from remote areas, and they can be sent. So ultimately, I would say that the goal of teleophthalmology is to decrease the global burden of vision-threatening diseases and also to improve the quality of life with the so much prevalence of eye diseases worldwide. Now, the detailed guidelines AIO is set to task, and there was a teleophthalmology committee that was formed, and we issued detailed guidelines by AIOS, which were circulated to all of us. And as and when more and more imaging devices will come, I think this will become a standard of care in due course of time. What is also important is that there is a lot of work that is being done on artificial intelligence. So teleconsult, teleophthalmology combined with artificial intelligence, the biggest amount of work is being done in diabetic retinopathy, and Arvind people are well aware. I think they are also collaborating with Google, etc. We are also personally trying to collaborate. So there's a lot and more work that is being done on artificial intelligence and on devices where non-mediatic taking of pictures of the fundus of diabetic patients can be done, and then they can be told whether they have diabetic retinopathy, etc., or not. And this is going to also allow the advancement of the care that is delivered at the doorsteps of the patient. So even not just in remote areas, but I think there can be incapacitated people or people who are afraid to move out of their house in the COVID times, that home care delivery can be done. There is a big chain of opticals who sell a lot of their opticals by doing what they call as the HTO or the home try-on. So that also, I would say, is a brilliant way in which you can have a teleconsult with a patient and also give glasses to that particular individual which is there. Teleophthalmology is also helping in devising ways and means by which you can test the vision of an individual, both near, distance, color vision, etc. And also there are devices from India which have come forward. I know of 2-3 which have been commercialized, by which you can do vision testing based on from a remote area onto an individual that is there. So all these things, these advancements are going to help segregate cases that require hospital visits from some cases that can be managed at home. One important thing that has happened is that if you look, there is a big company in China that is taking on, which is providing a 360-degree care, which can be home care, which is home physiotherapy, which is home delivery of medicines, which is teleconsults, and you can see advertisements in the television of Star Health, where they say that insurance that you can have a free consult with an ophthalmologist, etc. One important thing that does is that if you use these digital devices and softwares and teleophthalmology, by the time the patient comes to the doctor, almost 75 or 80% of the work is done. So it can also reduce the waiting time of the patients within the hospitals. So I think the digital world is there to stay. And I personally feel that if we don't adapt to it, we will be losers. So I think this society is a big step in encouraging people to join the digital revolution, as I would say, that is happening with internet prices crashing down. And everyone having a smartphone. I think this is the age today to get into teleophthalmology, digital ophthalmology, and patient care at the doorstep. So congratulations once again to all the founding members of the society, and I wish you all the luck and all the support that we can give from the AIOS platform. Thank you.
Thank you, Maipal. I think really wonderful. And Abhishek. Abhishek?
Thank you, sir. Thank you, sir. Thank you. Thanks a lot. So now I would like Dr. BNR Subudhi to kindly introduce the Secretary AIOS.
And also, I would like to tell both Maipal and Namrata, after we register, and we are planning to, we are actually in the process of also affiliating with All India Ophthalmic Society.
Great.
Welcome, Professor Namrata Sharma, our Honorary General Secretary, to tell a few words about her. I don't think she needs any introduction. I would say one word: strong lady of Indian ophthalmology, had done a lot of wonders and will be doing a lot of wonders in future too. And at present, she is working hard to get the referendum passed by 11th April. Really, I congratulate her and also our president, Dr. Maipal Sachdev, to get the required number of votes for the referendum. So I congratulate you. I want to tell much about Professor Namrata Sharma. She is herself a, what do you say, genius. And I request Professor Namrata Sharma, please guide us. Please give a few encouraging words for this Teleophthalmology Society of India, which is born today. So it is over to you, Madam. Dr. Namrata Sharma.
Thank you so much, sir, for having me here today. And I would like to congratulate the TOSI, that is the Teleophthalmology Society of India, for its virtual inauguration today, under the leadership of none other than Professor Natarajan, who is so much into teleophthalmology himself, and ably supported by Dr. Kim, by Dr. Subudhi, by Dr. Sabyasachi Patnaik, by Dr. Abhishek, Kavita Rao, Dr. Ashok Nanda, Sheila John, and all the others who are present on the platform. Just to say that teleophthalmology is the need of the hour, and as per the Indian Journal of Ophthalmology, an article that we read, 17% of the people were into teleophthalmology before the pandemic, and 98% of the people wanted to be in teleophthalmology or to take it up after the pandemic. So it is surprising, and it is a little unfortunate that it takes a pandemic for people to realize the importance of teleophthalmology. I'm sure it is here to stay, and it is going to do wonders both for teleconsultation, for diagnosis, for therapy. And we also should be aware of the limitations that are there. The limitations, it's going to have extensive outreach and also for timely intervention in emergency situations. It will avoid unnecessary referrals, will save cost, time, and effort, will help to provide health education, and also will help to take professional opinion more than one. Now, of course, there are some limitations, and I'm sure the Teleophthalmology Society will try and go above these limitations, which include acquiring of images, which include trained people or manpower for this, which include the regulations sometimes which can become difficult, which include the medical legal cases that may increase. But the good thing now is that the ministry has relaxed the guidelines for the training of telemedicine, and now earlier we needed 3 months training into it, which is not required. And I'm sure as it evolves, things are going to get simpler and simpler. So once again, I would like to congratulate all of you for taking this step forward, and thank you for having me here to speak on this platform. I'm sure it's born today, but it will grow by leaps and bounds. So thank you once again. As I stand on this platform, and I know there are so many leaders here, but I would again appeal to all of you to please vote for the referendum that we are trying to push at the All India Ophthalmological Society. We've had a very good response, and I'm sure we will reach the target. So thank you again for having me.
Thank you, Namrata. And I think you are doing a tele-voting now, which is also as a part of teleophthalmology. I think the pandemic has made a lot of improvements, and we are probably going to create a history again. Where thanks to Dr. Maipal and Dr. Namrata for making the society more democratic, and maybe 20,000 members will take part. Yeah, Dr. Abhishek.
Yes, sir. Thank you, ma'am. Thanks a lot. Now I may request Dr. Sheila John to kindly introduce the Teleophthalmology Society of India President. Kindly, ma'am.
Telemedicine Society of India.
Medicine Society.
Sorry. Telemedicine Society.
Sheila madam, we can't hear you.
Dr. Sheila? Dr. Sheila? Dr. Sheila, you're muted. Dr. Sheila, I think you're muted. Dr. Sheila, are you there?
I think there is some problem with ma'am's internet.
No,
Yes.
Yeah.
Now, Dr. Ashwin Goyal. I'd like to introduce Dr. Ashwin Goyal, founder member, President, Telemedicine Society of India. And he's also a member, the government, technical advisor to Government of India, Ministry of Health and Family Welfare, member of national and international telemedicine societies, member World Bank Health Sector, Skills Council Advisory and Technical Committee for Training of Healthcare Workers. A warm welcome to you, sir. I would request you to deliver your lecture, sir.
Thank you, Dr. Sheila John. Good evening, ladies and gentlemen. I bring you greetings from the Telemedicine Society of India. At the outset, I wish to thank the organizers of the Foundation Day of Teleophthalmology Society of India for inviting me as a guest speaker. I'm greatly honored and humbled to be able to interact with the enlightened audience on this momentous occasion. Also, on behalf of all members of TSI, I wish to congratulate you all on the racing day of Teleophthalmology Society of India. We all know blindness is a major trauma which affects an individual not only physically and emotionally, but also socially and economically. It is a major global problem. India was the first country in the world to launch the national program for control of blindness. However, there is still a huge burden of blindness in India. India suffers from a huge healthcare divide due to a shortage of doctors, with most concentrating their practice in urban localities. Additionally, the inadequate infrastructure of roads, telecommunication, transport, and financial status of the patients make it even more difficult to provide healthcare in rural areas. Teleophthalmology is a new branch of telemedicine that offers solutions to this serious problem. At present, some advanced ophthalmology centers are engaged in teleophthalmology projects like the Shankar Netralaya Teleophthalmology Project and the Arvind Teleophthalmology Network. These are proven successful both in rural and urban primary and secondary healthcare centers. Teleophthalmology is an effective screening and management tool for a range of acute and chronic ocular conditions. With improvements in image processing and better integration of the patient's medical record, teleophthalmology is fast becoming a more accepted modality, all the more so in circumstances where social distancing is inflicted upon us. Recommendations and policies from government and national health organizations, combined with social distancing, have led to an exponential increase in telemedicine use. Teleophthalmology has great potential to be integrated into ophthalmic care delivery. In the emergency room, teleophthalmology can be utilized to triage patients and diagnose common ophthalmic eye diseases. Ophthalmology practices can utilize real-time medicine to conduct many parts of an in-person exam. In cases where more complex diagnostic tools are warranted, a model incorporating telemedicine and focused in-person visits may still be beneficial. Innovative technologies emerging in the market allow for increased remote monitoring, screening, and management of adult and pediatric patients with common eye diseases. The COVID-19 pandemic has created a demand for healthcare delivery that limits in-person examination and entails potential viral exposure. Teleophthalmology allows ophthalmologists to continue caring for patients while keeping physicians and patients safe. Although challenges still exist, the pandemic has accelerated the adoption of teleophthalmology. And as Dr. Sharma just commented, it actually took a pandemic for us to realize the import of telemedicine. As a result, teleophthalmology will play an integral role in providing high quality, efficient care in the near future. And to this end, TOSI has an onerous mandate to bridge the existing healthcare divide in the country. To achieve this, I wish to recommend to this August Assembly to focus on three aspects of healthcare delivery. Firstly, to develop standards, protocols, and SOPs for provision of ophthalmic care. Secondly, to ensure capacity building of healthcare workforce, both doctors and allied healthcare professionals, including innovative and entrepreneurial activities in teleophthalmology. And lastly, to train care providers in the practice of technology-enabled healthcare. As you all know, this is very much in alignment with the avowed aim of Telemedicine Society of India to promote and encourage development, advancement, and research in telemedicine technology and its associated fields. Being a not-for-profit society dedicated to creating awareness of telemedicine at national level and carrying out scientific activities to promote telemedicine, TSI is recognized by the Government of India as the lead organization promoting telehealth in India. TSI aims to establish a pan-India telehealth network to facilitate delivery of healthcare by online teleconsultations. It is heartening indeed to see that many members of the TOSI are also the existing members of TSI. And I look forward to many more members of TOSI becoming members of TSI as well. As the president of Telemedicine Society of India, I wish Teleophthalmology Society of India all success in its endeavors to promote the practice of teleophthalmology. TOSI has a unique distinction of being the very first clinical association in India to formally embrace telemedicine in the form of an independent society. I assure you that the TSI as an umbrella body will extend all possible guidance and the required support to TOSI in attaining its mandate. Heartiest congratulations once again. Jai Hind.
Thank you, Dr. Ashwin. And I think on behalf of Teleophthalmic Society, we wanted to thank Tele Society of India. And I think Dr. Sheila Jan, Dr. Rajiv, and Dr. Kim had several sessions. And I'm glad I'm also a life member and I attended several meetings. And there's a session always given to teleophthalmology, even though we didn't have a society. And my classmate, Dr. Selvakumar, was president also. So at that time, we actually took part. So he was pushing for teleophthalmology for long, when from Ramchandra, even before the Tele Society. Anyway, glad for supporting us, sir. And I think, as you called it, we need your umbrella organization and yourself and your executive committee to support us.
Thank you.
Thank you, sir. Thank you for those encouraging words. I hope Teleophthalmological Society of India will gain a lot from the much more experienced Telemedicine Society of India. So now I would like to request Dr. Rajiv Raman to kindly moderate the scientific session.
Thank you, Dr. Abhishek. Thanks everybody for being part of this very important event. And I was just remembering 2002-03 when the Telemedicine Society of India was formed, and Dr. S.S. Badrinath was one of the founding members. So he had envisaged that ophthalmology, the telemedicine will play a very important role in the years to come. And that was a time it was ISRO having only satellite connectivity. And from there we have moved forward to we are now looking forward for the 5G technology, helping us in our telemedicine efforts. So without...
in fact, if I may interject, sorry for interjecting.
Yes.
I would like to enlighten the audience that Dr. S.S. Badrinath was the very first president of Telemedicine Society of India.
Yes.
Not only was he one of the founder members, he was the first president of Telemedicine Society of India.
Yes,
And I think he also mentioned that in the Dr. Abdul Kalam when he made that mobilized surgical unit, as well as when the then health minister, I forgot who was there, he announced in the stage also.
Yes.
With Dr. Kalam.
I think telemedicine is reborn, I would say. So TSI started by an ophthalmologist, president, being a president, and now we have Dr. Natarajan taking his student, taking it forward as TOSI. So let's start the scientific event, and it's my pleasure to introduce the keynote speaker, Dr. Hunter Chervek. And truly, he's a global ophthalmologist, and his specific interest is in how training and technology can be used to avoid avoidable blindness. When I was going through his slide about his CV, it's a very interesting mix, a mix of industry, a mix of NGO. Very rarely you get an opportunity to have both. So he's been part of Orbis for years, and today he has the post of Vice President Clinical Services. He also has the experience of working in industry Alcon for nearly 6 years in China. Welcome, Dr. Hunter. We are eagerly waiting to hear from you. Dr. Hunter.
Thank you, Rajiv. Can everyone hear me okay?
Yes, yes, Dr. Hunter. Welcome to our society. Thank you for
Thank you, Dr. Natarajan. I don't know if you remember, I met you 15 years ago at Adida Jot. So
yes,
you look the same, and I have more gray hair on the side, sir.
No, I've colored my hair.
I wasn't going to say anything, sir. So those are new technologies, as we like to say them.
Yes, but I'm glad you are there as the keynote speaker when I'm becoming the president. Thank you very much with the Indian namaste and welcome you.
Well, as you can see from my slide, the thanks is to you and this entire committee. And I am very, very honored to be here today. Today is my mother's birthday and it is a holiday here. So as soon as we finish, I need to take my mother out for breakfast. So I can say that I want to thank all of you for this opportunity to talk about Orbis. I think many of you know, and obviously Orbis has been in India for more than 20 years. And while certainly Orbis is known for the Flying Eye Hospital, today I really want to talk about Cybersite. And one of the things I'm going to ask is that you please go to the website now. So I'm going to probably be the only speaker who asks you to only half listen to what they say and go online and actually go to cybersite.org and look at the website as I talk. Because to me, it's like learning to drive a car. You'll learn nothing from reading the operator's manual or the owner's manual. You'll learn by doing. So obviously we have, and all the great panelists have talked about how the world's blind is going to triple over the next 30 years. And we need to be looking for force multipliers within ophthalmology to address these numbers. One of the things that there's never been a better time to be an ophthalmologist. In all of medicine, the FDA has approved the first gene therapy in ophthalmology in all the fields of medicine, and the first autonomous AI, meaning the artificial intelligence that is not reviewed by a doctor. The first of ophthalmology is currently dominating the field of artificial intelligence as well as telemedicine. So amongst the top 3 subspecialties are radiology, ophthalmology, and dermatology. It is incredible to think that in the world today, more people have access to the internet than clean water. More people have access to bank accounts than clean water. And this is all because of technology. So again, I encourage you to go to cybersite.org. We built this many, many years ago when I was just starting at Orbis, and it really started off for pediatric ophthalmology because at the time, digital photography did not have high enough resolution for retina photos or things like this. We were using it for oculoplastics and with strabismus. And certainly when we started Cybersite, the goal was to do 3 things. We wanted to provide content, live lectures and art books and videos, courses, and consultations. So I'll go through that, but I do want to let you know that over the 17-year history, we've done over 32,000 consultations, and we now have over 35 registered users in every country in the world, except for Antarctica, North Korea, and Western Sahara in Africa. And we use this platform to also integrate into our electronic medical records. So whenever we have an international volunteer going abroad, he or she already discusses the case on Cybersite. And when they land, they turn on their iPad and all the cases, all the histories are there in an organized manner. So one of the things I do want to talk about is the type of consultations. This is peer-to-peer mentoring. So these are not simple cases of a grandmother asking if their child needs glasses. This is a very high-level platform where we've managed over 950 cases of retinoblastoma around the world, looking at new treatments, intraarterial chemotherapy, etc. You can see from 2020 what we call the COVID bump, which is where really the lockdowns occurred, where really a lot of the doctors in our community used Cybersite as their primary source of CME, continuing medical education. Our consult numbers, as you see in the yellow line, are a bit low, and that's simply because we have not had the volume of doctors going abroad. But you can see both the number of users and the number of views going up. One of the things I'll talk about later is our webinar attendance. We have some of our best speakers are from India. I'm very proud of that. And on any given webinar, we have somewhere between 75 and 100 countries interacting and talking live. So the first thing we want to talk about is how we're using teleophthalmology for education. To me, the purpose of any source of material is to distribute it and make it freely available. So on Cybersite right now, you can take courses in Spanish, you can take courses in Chinese, but the majority of languages are in English. We have courses, and I strongly recommend you kick the tires and look at the courses in glaucoma, in diabetic retinopathy, and for cataract surgery. But we also have courses for anesthesiologists, nurses, as well as training like how to build a residency curriculum and how to become a trainer. As I said, we have webinars at least every week, and I will talk about the one we're having tomorrow to help support the TOSI launch. But you can see that we do live surgical demonstrations where we do a retina surgery, a cataract surgery, a glaucoma surgery. We talk about how to maintain hospital accreditation during COVID, but then also we'll have lectures by nurses, optometrists. So we all understand that it takes a village to give a child or a patient their sight back. This is something that Dr. Mahipal has already talked about, where artificial intelligence, I think, is really going to have a game-changing effect in ophthalmology. We've been in AI. Cybersite has been doing AI for the past 2 years. We have over 19 algorithms. We do not currently use it for autonomous consults. What we do is we first have, if the person wants to switch it on, that they can go through and see all the disease, whether it's exudates, dot blot hemorrhages, cup to disc ratios, macular thickening. All of this is freely available now. To the best of my knowledge, we're the only AI in the world that any doctor can go and sample and get free exams for glaucoma, retina, as well as macular disease. And one of the things we are using is not using AI at the moment to in any way replace doctors. It's more to help guide their decision-making. And before they have a human consult, they have a machine consult where they can go back and look at the fundus. Oh, okay, I see that hemorrhage, or, oh, I see that thickening, or, oh, I didn't realize the cup to disc ratio. I'm a retina doctor, or I don't look at the nerve. Every patient has a 0.4 nerve. And I'm very, very pleased to say that we're doing the first ever randomized clinical trial in Africa that started 3 days ago in Rwanda with one of our key leaders. Her name is Dr. Chiku Matenge. This will be a prospective study that not only looks at the accuracy and how AI is impacting rural access and review of diabetic eye disease, but it's also looking at the community's engagement. Are people afraid of this technology? Are they excited by this? Does this increase the quality of the patient experience, not just their diagnosis? We also are doing similar studies right now in Bangladesh, China, and Vietnam. I think AI is here to stay, and certainly we need to know how to best use it, not just to give a diagnosis, but how does it help the entire medical team? How does it help the community? Also, I'm very pleased that Cybersite has used teleophthalmology to connect the world with residency education. So where I did my training in Atlanta, the professor in the upper right-hand corner, his name is Dr. Yusuf Khalifa, he has set up a standardized wet lab where our partners in Peru go through the exact same curriculum, where they have to submit so many cases, take so many lectures, do so many quizzes before they can go to the next level of the surgical wet lab. So that, to me, I was once told that practice makes perfect. I disagree. I've seen plenty of doctors who try to go into a wet lab and self-teach themselves phaco, and they learn very bad practices because no one monitored them, no one structured their curriculum, and no one told them how to hold a phaco handpiece properly. So a lot of times if people don't have a teleophthalmology connection to their wet lab, they can actually create a lot of bad practices. This is to the extreme where we now have published several papers where after one of our doctors has worked with a fellow or done a hospital-based training where they worked shoulder to shoulder, we now are using live surgical mentorship where the doctor in the bottom left-hand corner is Dr. Larry Benjamin in the UK. He is still mentoring and helping the doctor in the bottom right-hand corner in Cameroon. And every week or every month, they set up cases where they want to learn new techniques with foldable IOLs or new nucleus disassembly techniques. And we have these around the world. So we are calling this remote surgical mentorship, where after they have established a good experience together in person, they continue to support each other in the operating room real time through live surgical coaching. This is also available on Cybersite. If you're on the website right now and half listening to me, then you listen to slide number 3, and that's a good thing. We have our entire simulation manual. It's 127 pages of exactly how to set up a simulation course, how to set up a wet lab, how to practice different techniques, whether it's cataract or small incision or strabismus. I strongly recommend that when you go to cybersite.org, you go to the right-hand column and go through the library and filter for simulation. This was recently picked up in the Financial Times, and we had a 5-day seminar on simulation for ophthalmologists, which you can take in the Cybersite library, which is also, when you go to the landing page, just click on the library and also the course sections. One of the things I'm very, very proud of, and I think some of you may recognize at least 2 of the speakers, one of our webinars recently took 3 of our top doctors in pediatric strabismus. 2 of them are from India, 1 is from Ecuador, and they gave a lecture on Duane syndrome. Now, I can assure you at a major conference like the AIOS or the AAO, if there were a lecture on Duane syndrome, I would say there'd be less than 20 people in the audience. And this just shows the power of teleophthalmology, that we had 102 countries live and over 1,200 participants. And what was even more impressive is after 1 month in the Cybersite library, we had 200 countries download or watch this webinar in review, and we've had multiple people commenting and continuing to use the Orbis resources. I think all of the speakers, and this is the importance of the TOSI Society, realize that we're never going to maximize the power of AI unless we work in partnerships. One of our partners at Orbis is Digital Diagnostics. I know you had asked for Dr. Michael Abramoff, the founder of this company, to speak. Unfortunately, he is detained today. He is the person who led the first FDA approval for autonomous AI. He has given and worked with Orbis on many things, including this lecture, which you can go to. And if you see my cursor, all you have to do is go to the library section of Cybersite, and you can hear Dr. Abramoff's lecture on not just how to do AI, but how to do it in an ethical and safe way. And that's one of the reasons why Orbis is very proud to work with Dr. Abramoff and his team at Digital Diagnostics, is their emphasis and review on ethics and safety, as well as healthcare productivity. And to help put an exclamation point on today's launch of TOSI, tomorrow on Cybersite, if you go to the webinar section, we will be following this conference with our webinar on AI, led by a clinician who is the medical advisor for our AI platform, Dr. Dan Neely, and the architect, the IT expert, Dr. Nicholas Jacquard. He is in the UK, on how you combine technology and clinical practice to maximize patient outcomes. So really, and again, I want to thank everyone for this opportunity. Orbis is driving during the COVID crisis, the Cybersite platform. It's up about 300 to 400%, depending on each month. And we're combining technology and training so that you can go to teleophthalmology for consults, for education, for curriculum, for courses, but now open access to AI. We are not currently doing autonomous AI. That is what our partner at Digital Diagnostics is doing, led by Michael Abramoff and his team. I certainly want to end this talk as I began by saying thank you. I certainly want to appreciate all the thought leaders and the incredible talent that is on this panel. I am certainly available to answer any questions either at the end of this talk or through email. And that really is the power of teleophthalmology, where I can be anywhere in the world now and answering questions from India or Bangladesh or Rwanda, and it only is going to grow from here. So again, thank you for this opportunity, and I'll take questions at the end of the panels.
Thank you, Hunter, for a wonderful talk. And I think we actually, for several months, I used to wonder because I went to Shankanetra yesterday and I was telling them I am now using the RTO 3D surgery, and Dr. Kim also has, and Rajiv has got the Alcon, no financial interest. But what I'm saying is, how do we teach 3D surgery to every part of ophthalmology? So I think there's an answer. And right away, I want to ask you, without asking my committee, as a president, I'm asking you, how can we work with you and have an MOU so that even this webinar can be a part of Cybersite? If you can do that, I know you need to do whatever paperwork and all that. We will do that, and whatever it says, we are in the process of registration. And second, I think all of us here are like, particularly I can see Dr. Rajiv Raman, Dr. Kim, Dr. Shira John, and maybe Dr. Subudhi. They're all good teachers. I know I saw Dr. Meenakshi and other speaker, and I also see many other colleagues from LVP, and I'm glad you came as a guest speaker, even though I know Michael, but I'm happy to have you to see how we can work together, because many of us have, at least I have a lot of time now, because where I can be teaching after my, I am now only 9 to 3 as the clinician, and rest of the time I'm trying to do research and charity and establishing, and we are also working with the again, no financial interest, with Remedio, using offline AI, and we got a publication in JAMA with trying to work with Alvin Liu in Johns Hopkins, and Rajiv and Kim are working. So, and as you rightly said, unless we work together, we can't progress, and we have to progress in, I think, in a lightning speed, because the AI is working like that. So India, I just mentioned, I don't know whether we are there in the inaugural part, we have 650,000 villages, and our Prime Minister is able to address them at one go, but we are not able to address them by doing a teleophthalmology to start screening. And this is my dream, where I want to make diabetic blind free India in next 5 years, and use teleophthalmology to screen for any patient above the age of 30, whether they have diabetes or not. So I want to know how, from Teleophthalmic Society of India, we can collaborate with you, and how you can use us and our members for teaching the whole world.
So I think you asked two questions. One is about the ingenuity in 3D technology. We have exactly that model going in Central America right now in the country of Honduras. So we actually installed and do 3D teaching in the operating room, and also have a connected wet lab. So the doctor in the United States demonstrates his surgery on Tuesdays. They display their live surgeries on Wednesday, and then they do a wet lab on Thursday. And they do that every week. So I do agree that visualization is critical, not just for AI, but also for surgery. You can't operate what you can't see. So yes, we are already doing that model, and it's working very, very successfully. As far as partnerships, obviously, I know you very well, sir. Anyone who is interested in Cybersite, I would first encourage you to go to the website and register. I would register for both the courses and the consult. Cybersite is not my baby, so you don't have to tell me it's cute. In fact, I would tell you it's far better to tell me the things we need to fix. So compliments are nice, but they don't make you better. I would be very interested in, India is obviously leading the way, not just in telemedicine in the world, but also on Cybersite. So that is one of the reasons why I was so pleased to be able to speak today. So maybe in follow-up, I don't want to delay the other speakers who I know have excellent talks, but maybe you can email me separately and we can discuss after you've had a chance to go through the website and see where you see the best opportunities for partnership and collaboration, either in research or clinical care.
Sure, I will do that. Anyway, I've already gone through, but I didn't write to you. I'm glad your lecture opened my new vista for me to do a lot of homework. I'll do that.
Thank you, Dr. Hunter. We'll move forward with the next talk. I would invite Dr. Helen. She is a director of Leoning He Eye Hospital Group Corporation Limited. She is currently also pursuing her PhD degree in public health from Queen's University, Belfast. And she has been procuring funding, maintaining the public relationship, designing numerous projects which are related to blindness. Welcome, Dr. Helen. We are very eager to hear you. Dr. Helen, please.
Thank you so much. Thank you. It's my great honor to share the teleophthalmology experiences in China from Heverin Group's perspective. So today I will be on behalf of Dr. He Wei, who is the founder and president of Heverin Group. Can everyone can see my screen?
Yes. You can make it full screen, Helen. And Helen, I know Professor He very well. My regards to him.
Okay, good. I think I met you, Professor, in Barcelona in 2018.
That's right. That's
right. Yes.
So, nice meeting you, Helen, and thank you for joining.
Nice meeting you.
Glad all the best for your PhD. We already have Dr. Sheila Jan, who just completed her PhD. Dr. Kim
Okay,
and
great.
Dr.
Great.
Vishwan are the mentors for it.
Okay, thank you so much. Thank you for Dr. Sensor's invitation. Thank you, Professor. So my talk will be divided into 4 parts. So first, I would like to just give you a brief introduction of the Heverin Group and also share the experiences, the information of eye care in China and also teleophthalmology in China. So Heverin Group was founded by Dr. He Wei. So you can see he is a passionate leader in blindness prevention in China and has more than 30 years experiences in ophthalmology. And now Heverin Group, we have already have over 100 eye hospitals and clinics and 1 university with more than 10,000 students in campus. And also we have 1 eye industry center, research center. So Dr. He is the chairman of Ophthalmic Pathology Committee of Chinese Ophthalmological Society, and also vice chairman of Chinese National Guiding Committee for the Prevention of Blindness in China. So he was elected as the board of trustee member of Ophthalmology Foundation just last month. So Heverin Group was established in 1995, and our group is one of the largest private vision group in China. So we are the first ophthalmic eye care system which integrate with the medical care, education, training, industrialization, and the research and development in China. So we are also the only 1 national GCP center in Northeast China, and also only 1 national eye genome bank in our group. So as you can see that in China now we have covered more than 10 provinces, and we have 30 eye hospitals, 30 eye clinics, and also 78 vision centers, which can provide primary eye care services in the local area. So for medical service, so it is the foundation of the Heverin Group. So He Eye Hospital is the national case specialty in China. And also we are the national training center for prevention and treatment of blindness, which was approved by the Ministry of Health in 2012. And also we are the training center appointed by the ICO in China. So as we all know that in China, one of the most serious problem is the myopia. So in 2016, we are approved as the Liaoning Provincial Myopia Control Center. And also we have the medical optometry institution certified with ISO 9000. So for the education part, we have 1 university, and He University was opened in 1999, And it is one of the modern wild and deaf universities authorized by the Ministry of Education of China to offer undergraduate programs, master programs, and also doctoral programs. So now we have 13,000 full-time students in campus from 23 provinces all of China, and 14 other countries around the world. So now we have one international education college. Now we have more than 200 international students in campus. Most of them are from Africa, from Asia countries. And for R&D part, we have a research center which was approved by 9 ministries of China. So we developed consumables and AI-based equipment, and also some drugs for eye care. So we have already built up 3-level eye care services model in China, which you can see is a sustainable and high quality, large scale and replicable, low cost and payable eye care model. So Professor Yunus from Bangladesh, he also talked and discussed with Professor Wei to duplicate our model to Bangladesh. Now our model has been already applied in Bangladesh by Professor Yunus. So here is, you can say, the eye care in China. The main eye problems is the cataract, refractive errors, diabetic retinopathy. So the most serious problem is refractive errors. So, but in China, there is a lack of human resources. As you can see from the chart, in China, we have the human resources are very low compared with other countries, even comparing with the other developing countries like Brazil. So Chinese central government has paid more attention, has put much strength for human resources. Like I introduced, our group has approved by Ministry of Health as the only one national training center for prevention and treatment of blindness in China. So how the teleophthalmology works in China. So for our group, we are trying to set up a unique teleophthalmology model in China. We set up a telemedicine system combines with the training and education. Also, we combines with intelligent equipment. As just now I introduced that in our group, we have a research center, but not only in China, but also we have a research center in Italy. So these two research center and the research teams, they developed a lot of smart AI-based equipment. So this picture shows that the telemedicine system works in our group. So we equipped the fundus camera to the county level hospitals, and they can take the pictures from their hospital and to upload the picture to the telemedicine system, in which located in our group, and then they can get the feedback within 10 minutes or 5 minutes. So this model is not only applied in Liaoning province, but also in whole China, because we did several national programs, including diabetic retinopathy screening programs in other provinces, like in Guizhou. This picture shows that the project we implemented in Guizhou province, which is the located in the western part of China, and very low resources in ophthalmology and also the human resources. So we equip them with the smart equipment, and we organize the online consultation with the doctors, and we also provide them online training for them. So for training and education, just use our training center to provide the different kinds of trainings for them all over China. So till now, we have already trained more than 30,000 trainees all of China. So this picture shows that what kind of the trainings we can provide. So the training course is divided into several parts, but mainly two parts. One is cataract surgery team, one is refractive error team. So in cataract surgery team, we provide the training for surgeons, cataract surgeons, and operation theaters nurses, and also screening, personnel training, project manager training. But for the refractive error team, we provide the optician training, refractions the training, and shop manager training. So after the training, they can make up their own team and to provide the eye care services by themselves. We worked with Orbis very closely. Just now, like Hunter said, we cooperate with the Cybersite, with Orbis, provide the online training, live broadcast all over the world. Now we usually provide the training twice every month.
Hello.
We also did organize some virtual forums. As you can see, from 2018, we organized this third forums focused on Africa. So set for Africa Eye Health Forum. So this year, last year, due to the pandemic, so the forum went virtual. So this forum, we have got more than 500,000 people online. So in China, because now we use 5G, so we use the social media like TikTok and WeChat, and we do provide the online public education from the social media. So at least once a week. So the topics can be very covered most of the subspecialties. So for the smart equipment we used in the telemedicine system is, as you can see, for this on the left is the portal refractometer. This is intelligent refractive screening tools. And on the right hand is a portable slit lamp. It is AI based, so it can be easily used and attached on the phone. So we equip this to the grassroots doctors who didn't have the ophthalmology knowledge, but they can use this. They can just take the picture and then upload to the cloud. Because this is a big data and AI based, so they can have the feedback, have the result within 3 seconds. So this smart equipment is the 2WinS. We call it Kledos. So it is portable and light independent, very fast and accurate. So it can only take 3 seconds to screen one child. So we don't need to a specialized person to make the measurement, and has been used in school screening in China and also in Europe and also in some Asian countries like Philippines. and some in America also by some NGOs. So this is the portable slit lamp used in primary eye care centers. So not only in China, we also practice the teleophthalmology in other countries. Like just now I mentioned in some African countries, like Nigeria, Rwanda, Ethiopia, and Uganda, and as well as Mongolia. So this is the program that we implemented in African countries. So in Asia, we launched a program, also used the teleophthalmology in Pakistan last year, last September. So this program will screen more than 1 million students in the whole country in Pakistan. So this program was launched by Hebei Group and the DEA Group with a great support from the Chinese Embassy, Pakistan Embassy as well. So we will use the smart equipment and also combine with the online training and also the practical training. So next step, we would very much to have the opportunity to discuss the future collaboration with Indian professionals. So maybe we can discuss the possibility that the application of the smart equipment and also the online trainings and also practical trainings as well to work together. Thank you so much.
Thank you, Dr. Helen. So it's really a good insight, and we are looking forward working with your group. I am sure many of the people who are here who are practicing telemedicine would look forward for these type of intelligent devices, and I'm sure that's the future, especially the AI-based cataract screening. I think that is something which many of us, because cataract still is one of the leading cause of blindness in our country.
That will also help the solo practitioners, those who are interested in doing teleophthalmology.
Yes, yes. Any questions from anybody for Dr. Helen?
I was just seeing she had mentioned something about refraction, intelligent AI-enabled refracted, which is quite, it looked like a pen or some device. So I just wanted to for refraction. When you do community,
wants to know what is your device. It looked a very sleek device, something for assessing refraction.
Helen, can you hear?
Yeah, I can hear. So you mean just now I shared the equipment that we used in refractive error screening programs, right?
Yeah, that's what I wanted.
Yes, that equipment is portable and very convenient to use. So it's developed by our Italian research team, research center. So now this equipment has been used for many countries in Europe and also in some Latin America countries as well. So that equipment don't need to a professional, but school teachers can use very well, and they can give the result within 3 seconds or less than 1 second.
Helen, you can show that instrument. You have the presentation with you.
Yes,
that refraction instrument.
Yeah, this one. Yeah, this equipment is very useful for the large volume screenings, like especially like in China, because in China, the central government has put much effort on myopia control. So this equipment will be used for, has already been used for in several provinces in China. And from next month, we will implement another national programs in several provinces, like including Beijing and Hebei, and also Guizhou province. So we will cover all the
Is it possible to use this instrument? Am I in India? I don't know what's the format.
Yeah, I'm in talks with Helen and Adaptica to get this equipment to India. So hopefully we'll be having two of those equipments soon. So we will be bringing it. I've been in discussion with Professor He also. So hopefully.
Okay. So you're bringing it.
Yes.
Great.
Yeah. We can make contact directly, and also you can contact with Professor He Wei as well.
Yes.
I had a comment, a wonderful talk, Dr. Helen. So I was also wondering, just like this portable refractometer, I think if you could come up with something where there's a Placido disc, and you can use that for also doing an on-site screening for keratoconus. I think that also would be something really useful. Picking up keratoconus, especially in the younger age group and areas where they're not able to go for a corneal topography. I mean, I'm sure a similar sized instrument can be made for that as well.
Yeah, we always use this. Yeah, we always bring this equipment into in schools, and we just train the teachers, and they can screen the students by themselves.
Thank you, Dr. Helen. So we move forward with the next talk. I would request our president, Professor S. Natarajan. He'll be sharing with us his experience on working offline AI in screening for diabetic retinopathy, screening, diagnosis, and treatment. Dr. Natarajan, please.
Thank you, Rajiv, for asking me to share my experience. So I'm using the teleophthalmic for screening for diabetic retinopathy. So that's why I'm calling this as a Diabetic Blind Free India 2025. So there's no financial interest, and we have an NGO which is given. The name is given by the former president, Dr. Abdul Kalam, the Aditya Jyoth Foundation for Twinkling Little Eyes, and this was the inaugural diabetic screening van by the former president, and my best friend Shivanandan is there. We started the first carrying these 4S. I don't have financial interest. The 4S fundus camera, now which has AI also, and you can see the CEO, Mr. Chandrasekhar, and my late grandmother was 103 inaugurating with my late father, eye doctor, and friend Shivanandan. And we all know that World Diabetes Day is November 14. So as a president of All India Ophthalmic Society,
মিষ্টি মামা হরিয়াতে তুমি ইয়র থেকে ওই ফোন থেকে কইয়া দাও না পুরো স্ক্রিন গেছে গে স্ক্রিন গেছে এখন আমার
Hello? Hello? Yeah. No, somebody should mute. Okay. So we are, as an All India president, I inaugurated a screening through teleophthalmology to prevent diabetic blindness. We called it in Hindi, and we all know that the diabetes is an epidemic now happening. And this is a coin between Indian Medical Association and All India. Dr. Babu Rajendran coined it. Diabetes invariably affects both eyes. Test your eyes soon. And this is the IDF which gives the statistics for India, and we'll have for the world from 2015 2040 it will be 415 million diabetics, and according to the International Diabetic Federation, India has 77 million diabetics. In fact, by 2030 it will become 101, and by 2045 it will be 134.2 million. And among this 77 million, 58% do not know they have diabetes. So the only way to use teleophthalmology to prevent blindness, and not only that, to screen them. And that's why the old preventive and social medicine dictum, prevention is better than cure. And here I have a short video which okay, it's not working, but some. And the whole idea is to create awareness, and that's why All India Ophthalmic Society has a committee called the Diabetic Retinopathy Screening and Awareness Committee, for which I chair, and many of us from this are members. And our motto is not only to screen, diagnose, but to treat. So we also do project with the UK called the Smart India, and several hospitals are doing in India where we screen, diagnose, and treatment. And as India is leading in cataract surgery rate in the world, and I think the highest cataract surgery is being done. Similarly, we want to do the screening for diabetic retinopathy and treat them. We have this process flow for a nationwide screening, pre-camp awareness, assembly of diabetics, capturing of images, diagnosed by ophthalmologists or by image graders at reading center, offline or online AI. And we all know the various types of diabetes. We need a multidisciplinary approach and better primary prevention by metabolic control, lesser rate of developing progression of diabetic retinopathy. Still, a significant number of patients continue to develop vision-threatening complications that require intervention. So the problem of healthcare in India, we have one ophthalmologist per 100,000 population, low awareness or ignorance, and 70% of Indian population resides in rural area or on urban slums. The technical difficulties, unreliable internet coverage, deficit in supply of electricity in many areas, shortage of trained medical staff for operating conventional fundus cameras, and portability of conventional fundus cameras. And this is what I keep telling, the role of artificial intelligence. Intelligence is the capacity to analyze, think, make a decision, and categorize. And artificial intelligence involves formulating a specially made algorithm according to our need to develop this capacity and include it in an electronic device like smartphone. And this is again no financial interest. This is a company in Bangalore which is made in Bangalore in India, where you are attaching the iPhone with the infrared device, can be mounted on a suitable bike for transporting, can be mounted on any table. You can use it as a handheld or as a slit lamp model, and it's chargeable. Why I said you don't need electricity, you can charge the mobile phone, you can charge the infrared device, and you see the connections, and then you can take it. So I use this term, anybody can be trained to screen for diabetic retinopathy. That means there's no need for education, no need for technician. And we have done that in the slums in Mumbai. They cannot read English or write, but they can operate a smartphone. Hence, they are being trained in this, and they can take and screen photographs, and the offline AI can be. So here you see the using the mobile, and you can see this is a photograph taken by a boy who's just a school dropout, and you can see he knows which button to press, and then right eye, left eye, and then you can see this is a Meteor software which is developed in Singapore, and you can see the blue things which are there, which is the area which recognizes the abnormal thing happening, and that means the diabetic retinopathy where there are exudates or hemorrhage, and that picks up, and then it says referable diabetic retinopathy or non-referable. So the idea is this can be taken to villages, and thereby anybody can use this for screening, and then we can refer, and we can take any number of photograph, and this is one of the fundus on phone and a Zeiss, which is comparable, and this is the AI. You can see the various stages of diabetic. You cannot stage every stage, but at present you can say referable and non-referable, but they're also working on all the stages of diabetic retinopathy. And this is again a field level, and how automated uploading of images, diagnose and treat the link. So is AI reliable to those in need for seeing an ophthalmologist? So this is what is published in JAMA Ophthalmology, the diagnostic accuracy of community-based diabetic retinopathy screening with an offline AI system on a smartphone. And thanks to Dr. Alvin Liu from Johns Hopkins, who already made an instruction course in academy that this is not only future, this is going to be useful for the entire rural India, Africa, and South America, where the reaching and the distance is the problem. And this is the first of its kind in the world, use of offline AI for screening of diabetic retinopathy, using a non-skilled worker, giving him or her training, and making him a semi-skilled health worker in the Municipal Corporation of Mumbai, where we are doing free. And Telemedicine Society, Dr. Ashwin mentioned, let us do free, and we are already doing, and many hospitals in India are doing. And this is a pilot study we did, and this is what last year it was the most viewed article. We had 4,004 and most cited in the last 3 years. The reliability rule out non-diabetic retinopathy case drops to 81.9% if the images are poor, but referral diabetic retinopathy cases were still correctly marked as with 100% reliability. So reliability of AI for screening population for diabetic retinopathy in need of ophthalmology checkup by an eye doctor is 100%, and that's what we need. And the advantages of using AI, whether offline or online: early referral of referable diabetic retinopathy, greater awareness about diabetes, its effects and importance of regular follow-up, greater chat time by an ophthalmologist to a patient for the diabetic retinopathy management, timely medical surgical intervention to prevent complete loss of vision, more job opportunities, more working hands, skill development of less educated. So points to remember: the trained and employed youth of India, even with minimal minimal education and no experience in fundus photography, to reach out to save vision of millions, independent of electricity and internet supply, better chat time for eye doctors to examine the referred patients, timely treatment is preventing blindness. The main problem which all of us face in India is because people think that when the vision is normal, the retina is normal, which is what I think we are having a big myth to be broken, and we all want everybody to join hands for this monumental revolution, fight against blindness from diabetes. So these are 3 generations we are working on 150 years of service to the nation. And my inspiration is Swami Vivekananda, who mentions, arise, awake, and stop not till the goal is reached. And the goal is all the 77 million to be screened. And I think if we find diabetics at the age of 30, 35, you can teach them what diet to take. You can teach them by simple oral anti-diabetic to control the diabetes, and also teach them exercise so that you have a healthy individuals who will be having a healthy nation, so that you can, and India has 65% of the population, which is young population. And if you can screen them and make them healthy, they can live longer and be productive to the country. So thank you very much for the patient listening, and I'm open for any questions.
Thank you, Dr. Natarajan. So I think one thing which we can learn from Dr. Natarajan is if he has that passion for diabetic retinopathy, right from doing the screening in the slums and now adopting with the newer technology of AI and really translating it, showing how it can translate in clinical practice. I think kudos, sir. And
thank you. I also wanted to acknowledge publicly Dr. Rajiv Raman and Professor Kumar Manikvel came. We did a 2-day workshop for all the workers, and Dr. Rajiv Raman spent 2 full days teaching them how to do and the importance. And I think that's going a long way, because we have that photograph, which I think I forgot to show. So I apologize, Rajiv. But I think, so that's a real teamwork. We have 90% women, and all the community health workers are women who can do this, and I'm happy they are still doing, and it's miles to go before we sleep. And I think that's what I want to stimulate through the Teleophthalmology Society, that anybody can screen for diabetic retinopathy. As he says, I think if everybody can see well, live healthily, I think we'll have a healthy India.
Correct, correct. Any questions for Dr. Natarajan? Anybody?
Not a question, but a suggestion. I think we, on behalf of TOSI, also can take it up as a model for a diabetic eye screening program for the entire country and propagate that. And we can invite others, anybody involved, anybody interested to be involved in this program also. So we can develop that as an SOP or a role model for the diabetics.
Thank you, Sabyasachi. Hunter, you have any point or suggestions to improve our using the offline AI?
No, and one of the things I love about working with you is you try to globalize and increase access. And that's the one thing that's exciting. As I said in my talk, more people in the world today have access to the internet than clean water. How can we make our smartphones smarter? And how can we use this leapfrog technology so that everyone can identify the problem? I do think the ultimate thing in teleophthalmology is not telediagnosis, but teletreatment. How ultimately can we automate PRP? How can we, so to me, democratizing education, democratizing access to diagnosis and care are the critical things we need to drive. And that's what, sir, you and this panel are doing. And so for me, I've always been about democratizing education. And I think that's where I see a lot of opportunities for collaboration.
Sure. And I think, Hunter, you don't have to call me sir, because I look
younger than you.
I look younger than you.
Okay. Well, All
Only
right.
look. Only look.
Well, yes, you need to get your glasses then, sir. You need to get glasses.
Oh.
Thank you. Thank you. So we'll go forward with the next talks. I would like to invite Dr. Kim Ramaswamy from Arvind Eye Care System, a very good friend, very humble person who has really works in silence, and the amount of work in teleophthalmology which he has done, I think no match for him in this country. I would request Dr. Kim to share his thoughts on teleophthalmology in India.
Thank you, Dr. Rajiv, for that introduction. And I want to thank everybody for this beautiful work that we all can share and learn from each other with this society. Because I don't have any financial disclosure in this presentation, we all know that India is one of the country with the largest number of blind people in the world. The problem is creating access, how to reach everyone in need of eye care, especially when you have to reach them early enough, and how to improve compliance and continuity of care. Well, last year totally changed a lot of things. Everything, with the advent of COVID, everything stopped. Doctors had no way to reach out to the patient. Patient did not have ways to reach out to their doctors, especially those who needed care, continued care like diabetic retinopathy, age-related macular degeneration, patients with advanced cataracts, trauma cases. But then a lot of innovations, this did bring in a lot of innovations and protocols that got developed. And that's how telemedicine or teleophthalmology really opened up in a big way. I mean, teleconsultation as a solution. Many of the hospitals opened up teleconsultation directly to the patients, where the patients could actually reach out to the doctors. We did open up quick solutions at Arvind. Shankar Netralia opened up, tied up with Titan, the optical showrooms, to do teleconsultation for their routine, already registered patients to whom they could do the consultations. And of course, a lot of business ventures opened up. It was a real opportunity. Many of the IT companies opened up these platforms for doctors to reach out. And today, that has become the way, like many, especially big institutions like Shankar Netralia, LV Prasad, and Arvind have opened up teleconsultation as one way of, as a service to the patients on an ongoing basis. This really has created an access. And the best boon in this sad situation of COVID was the opening of the telemedicine guidelines by the government of India, the telemedicine practice guidelines, which made it legal for us to practice ophthalmology or telemedicine in our country. So today we really have a legal way of reaching out to people. We don't have to be worried about, when you do a teleconsultation, as long as you're following the guidelines. We at Arvind have been practicing teleophthalmology for almost 2 decades now. For the last 16 years, we've been working with these primary eye care, what we call as vision centers, and of course, secondary eye care is what I call it as screening for other diseases. The primary eye care, we started these vision centers to address actually the issue of eye care. This is the first in the world to open up a center like this, where we opened a small clinics for every 50,000 population, which is manned by 2 ophthalmic technicians. These are permanent facilities, functions just like a hospital 6 days a week, equipped to provide comprehensive eye care. And basically it is there to provide primary eye care and referral service. So what happens, the patient gets registered, the technician there does a complete eye examination, just like what a doctor would do, including vision test, refraction, slit lamp examination, applanation tonometry. They even do a height, weight, BP, and all those stuff. All the data is entered into an electronic medical record, and then a final consultation over web is done by the doctor, an ophthalmologist at the base hospital. and the doctor is able to view all the patient data, and also if any images like fundus images were relevant or anterior segment images would be attached to this, they are able to see the image. And then the best thing is they are able to talk to the patient, which convinces the patient that they are being actually treated by the ophthalmologist. And then the most important thing is to close the loop. Like, the medicines are made available, glasses are made available. And it was surprising to see 90% of the patients could be handled in these vision centers. Only 10% need to be referred to the base hospital for further management. So it's like a hub and spoke model. We have for every base hospital about 10 to 30 vision centers attached to it. So these patients, the doctors sitting in the base hospital able to consult with these, patients. So it's now considered the best last mile connectivity in any healthcare intervention, because it gives access to care. People who are actually not accessing care are now reaching out because it's locally available, no dependence on attenders. There's a lot of time and money saved, and compliance to care is much better. Today at Arvind, we see almost more than 2,000 patients across. We have about 80 vision centers, and we see a little more than 2,000 patients consultations each day. I was just wanted to talk about this EC made by Oral Lab. This is also an automated autorefractor. This does not just objective, it also gives a subjective refraction. So the basic idea of introducing devices like this, especially in the vision center, is to do away with having an trained ophthalmic technician. Now, if, as Dr. Natarajan was pointing out, if we could have even an unskilled worker operating these equipments, these people could triage the patients in those local places, so that only those who really have eye problems get to go to the hospital. So, the time for both the doctors and the patients is not wasted. Only those who really have problem go to the ophthalmologist at the base hospitals. So as Dr. Natarajan calls it, the chair time is much better for the patients who really need care. And this is one of the best model. Like, we helped Tripura the state of Tripura to establish about 41 vision centers. And this was our first outside venture where Arvind's team went and established these 41 vision centers for the Tripura government, which happened in 2007, and it's running still very efficiently. And this is one of the showcase that the government does with, about these vision centers and telemedicine. And also Chhattisgarh, Jharkhand, and even Tamil Nadu have opened up now vision centers from the government side. We're also establishing vision centers in Bangladesh. The government of Bangladesh is planning to start 400. They've already covered almost 80 vision centers as of today in many places in the country. The other side is the secondary, which we are all aware of as ophthalmologists. One of the best disease that can be easily diagnosed, which is the image-based diagnosis, is diabetic retinopathy. Earlier, both Shankar Netrali and Arvind, we were using these mobile vans, as Rajiv pointed out. Thanks to ISRO, we had these satellite-connected vans, which have now become obsolete with the advent of new technologies like 4G and 5G. We are able to screen these patients. These are opportunistic screens we continue to do in the diabetic clinics, because they are the places where the diabetic patients are there. All our target population is there. So we trained the technician at the diabetic clinics to screen their diabetic patients, take pictures, send it over internet to our reading center, where one of our retina specialists or a trained grader looks at these images, gives a report and sends a report back, where the doctor is able to counsel the patient if he needs to go see an ophthalmologist or come back for another eye exam after a year. Now, this is what we call as an opportunistic screening within about an hour. Just like how he gets his blood test results, his eye results are there. So if you have an eye problem, refuse to go to the ophthalmologist, even if you tell them. But at least here, you're able to screen them right when they are getting their diabetic checkup done. And only those who have any problem need to be referred. We are continuing to do this even in some of the primary health centers, where the patients, actually the diabetic patients, come to collect their medicines once a week. So we ensure our team goes there, and that week, only if their eyes are examined, the PHC doctor actually gives them the medicine. If they don't have their eye exam done, they do not get the medicine. So this is one way of ensuring that all diabetic patients get their eye exam done. So this is becoming really a way of reaching out to people, and it's becoming quite widespread. Dr. Sendel will be talking about those wonderful business models that are emerging out of this system. Another condition is the retinopathy of prematurity, which is now being widely screened. I mean, using telemedicine. Our entire team almost covers the entire state of Tamil Nadu, across all our hospitals, where our team goes, even to the government hospitals, NICUs, where our team goes, does the telescreening of these babies. The images are read by doctors, and then we are giving a report back. With the, Rajiv and me have been working with the Google team to work on this artificial intelligence algorithm. And today we are able to use it in real time in many of our centers, in our diabetic centers. We are using this algorithm to screen the diabetic patients, where earlier we had to use a grader. Today, just within a minute, the images, the data is there regarding. It also gives the grade of diabetic retinopathy to a high accuracy. And so instead of waiting for 1 hour, the patient in the diabetic clinic is able to get his result within a minute, less than a minute. So this is not just stopping there. It's also, the research is going on for predicting the progression of diabetic retinopathy. Patients who do not have diabetic retinopathy today, if their fundus photos are taken, there is an opportunity to know whether this patient is going to develop diabetic retinopathy or not. This is something phenomenal. And people are also trying out, research is being done just by taking external external photographs, anterior cerebrum photographs. Trials are there to show that they are able to detect diseases like diabetic retinopathy and AMD, which is phenomenal. I think this looks very futuristic, but believe it me or not, it is going to be there in the short time. We will have this in place. Today, there's a very enabling environment for usage of telemedicine or teleophthalmology. We have national broadband availability through all the mobile networks. As Rajiv pointed out, we will have 5G soon. With this, I'm sure, teleophthalmology will go a lot of ways. So teleophthalmology is definitely here to stay. And along with that, with the use of artificial intelligence, I think we'll see a lot more changes. And then the doctors will be working on only the clinical aspects, or as patients who really need care, rather than screening through patients for finding the diseases. And thank you for your patient hearing. Happy to answer any questions that you may have.
So,
thank you, Dr. Kim.
Can I ask one question, sir? Dr. Kim,
sure, sir.
What are the minimum equipments required to run a vision center, and what will be the minimum expenditure to run a vision center?
For our model, it's about 5 lakhs. We just have a basic slit lamps, and now we are also putting fundus cameras. Earlier, we were just putting a $300 camera attached to the slit lamp, which was giving basic images for both anterior segment and posterior segment. But now slowly we are adding other equipments to see how best we don't have to rely on a trained ophthalmic technician. We are looking at from a skilled to an unskilled person who can triage patients, because then you really can reach out to all the remote areas.
So one question, sir.
Sure, madam.
Most teleophthalmology programs, we need funds to run. Is your program self-sustaining?
Yes, in a way, because for the capital expenses, we had funding from other places. But once we have them running for its day-to-day running, it has become self-sustainable. We charge 20 rupees to the patient as a consultation fees, which is good for 3 visits or 3 months. But there's also money on doing blood sugar, also on sale of glasses and medicines. So all this help to run these vision centers. But your reach is very high. You're able to reach out to those people even those people who were not accessing care are now reaching here.
Because teleophthalmology is not financially viable. So somewhere you need either for the capital expenditure or recurring expenditure, we have to look for funds. That's the
It depends on
problem.
how you see them, madam. I know this is not the forum. We can definitely have a forum to understand this, or even a complete symposium on how to make telemedicine a viable option.
If it is financially viable, I think many people will adopt it.
Yes.
That's the difficulty.
Dr. Sheila, we'll have probably some answer from the next talk too, and we can definitely have another session on this. Yeah. Thank you very much, Dr. Kim. And now I would request the last speaker, Dr. Senthil. And if you can see his slide, he's an ophthalmologist and healthpreneur. It's like something which I have not heard about healthpreneur. It is an entrepreneur who looks into the health. Welcome, Dr. Senthil. He will be talking us something about future of teleophthalmology. Dr. Senthil, please.
Thank you, Dr. Rajiv, and I thank the previous speakers because they have left at the correct point we have to discuss. Because is teleophthalmology financially viable? I think that was the question, and maybe the future of teleophthalmology also depends not only on the AI and data learning and new equipments, but also it depends on how financially it's going to be viable for individual ophthalmologists and how can they adapt it into the practices. I think that is going to decide on the future of teleophthalmology. And to quote an example, I have been doing teleophthalmology over the last 5 years, and I think I've been surviving, I'll say 80% of my work is now teleophthalmology. So I've been able to make a living out of teleophthalmology. So definitely it's financially viable. In my journey over the last 5 years, I also raised some funding from venture capitalists, and I was able to give them a return, and then so it's definitely financially viable. I thank Teleophthalmology Society of India for starting this because when I started teleophthalmology 4-5 years back, there was always these questions: is it legal? Is teleophthalmology legal? Is it a recognized entity? And is there support from the government? And what happens if something goes wrong? And I think there were 2-3 things which happened over the last 4-5 years, which actually changed everything and made it more legitimate. The teleophthalmology is something legal. So I think the future of teleophthalmology also depends on making it legal and in a regulatory environment also. So I have been given a very tough job. It's very difficult to predict the future. Like we are having this Tamil Nadu elections on Tuesday, so we can never predict whether DMK is going to win or ADMK is going to win. So it's very difficult to predict the future. But as Peter Drucker said, the best way to predict future is to create it. So hopefully Teleophthalmology Society of India and all of us together can create the future. I think it's better to create future rather than to predict the future. And with the COVID wave coming in and basically second wave and third wave, I think we are all having this huge hopelessness. And I'd also like to quote Martin Luther King saying that we can accept some finite disappointment which is brought in by the COVID, but never lose infinite hope. So I think that's more important to keep going. And for telemedicine models, definitely the COVID has brought in a lot of support. So I think in March 2020, the whole thing changed in telemedicine when the Indian government brought in the telemedicine practice guidelines, which changed the way telemedicine has been practiced, which also gave a legality for practicing telemedicine. I think the future also depends on following our practices based on the telemedicine practice guidelines. So I would touch upon, rather than talking on the future, like what are all the models of teleophthalmology which are present now. I would also like to thank the previous speakers because they have covered most of what I wanted to talk. But maybe I'd like to summarize it. So the first model is direct-to-patient teleconsultation, where just like patient sitting at the home and the doctor in a hospital, so you try to talk to them. But unfortunately, this model doesn't work too well in ophthalmology, because ophthalmology is a specialty which is dependent on imaging, dependent on getting a lot of tests from the patient. So it doesn't work like psychiatry, where it's pure consultation based, or dermatology, where you just take a picture of the skin lesion. So a direct patient teleconsultation, apart from just giving a small second opinion, might not work in teleophthalmology. So ophthalmology has been one of the specialties which has got very less number of direct patient teleconsultations, basically because of imaging and getting a lot of information which you have to get from the patients. The second model which might work is teleconsultation in healthcare facilities. Like the patient is in a hospital or in a diabetes center or in a general hospital or in an optical shop, where you are able to do those basic testing like a slit lamp or fundus imaging and all those things done in a healthcare facility. And then you do a teleconsultation. I think this model might work, like the one followed in Tripura and even the government of Andhra Pradesh, where they've converted the primary health centers into teleophthalmology facilities. I think these kind of models can definitely work rather than a direct teleconsultation facility. Dr. Kim was speaking about the mobile vans, where you go into the community with these vans and then you screen patients for telemedicine. So a lot of these optical chains have been exploring this model, where they are going into the villages or where they are reaching out to population and screening patients using these mobile vans. But the financial viability definitely is something which has to be concerned. So investing on these huge mobile vans and then whether the patient is willing to pay, and you have to look at those models. So unless it's a funded model, might be a slightly difficult to sustain these kind of models. I think one of the most successful, viable, financially remunerative model has been in the diabetic retinopathy screening, as seen in my experience also. So where you set up these teleophthalmology or screening facilities in diabetes centers, patients pay for it, and then these images, just like teleradiology, because the most successful model in telemedicine over these many years has been teleradiology, where the radiology images are uploaded and then patients are getting this opinion from radiologists on a remote model. So in ophthalmology also, I think one model which is more successful is the diabetic retinopathy screening model, because India, as you see, has got 60 million diabetic patients, and most of them don't have an access to ophthalmologists. So setting up a teleophthalmology diagnostic screening facility in a diabetes center or a general hospital or even an optical shop, and then getting those images and reporting, has been the most financially viable and successful model as of now. So this is the model which I've been following in my company, where I set up these fundus cameras in diabetes centers, and then we have created a platform where these images get uploaded, and I have a team of ophthalmologists who do the reporting. And it's not a charity or a funded model. Everything is self-paid, patient pays, and then even the diabetologist charges X amount, where he also makes some revenue out of it. So I think these kind of models where there is a financial component, where there is a financial benefit also, right from the patient to the physician. Even the patient has a financial benefit because he is getting these screenings at the level of a physician center at a low cost. I think these are the models which will become the future of teleophthalmology. So retinopathy of screening, I think this is another model, because when it comes to babies, the parents are willing to pay. So maybe if we have models where there is a financially viable model for screening of retinopathy of prematurity, I think this is something which we could explore as has got a great potential in the future. The kiosk model is also coming up. This company Globe Check, where they set up a globe where all these equipments are kept inside, and right from an OCT to an autorefractor to an NCT. and patient keeps moving in the globe, and then all these images and reports are transmitted to an ophthalmologist in a remote location, and the patient gets these reports with the glass prescription. I think this might have its own success, but whether the cost of implementation of this kind of a model, we have to look into that. And now everybody is also focused on the kiosk kind of a model where you can just go into a kiosk and get your vision checked and get the glasses prescriptions. Hopefully in a pharmacy or in a maybe even in a diabetes center or in a railway station, if you can keep these kind of kiosks, it can become more model which can be successful. And in India, I think something teleoptometry has got a huge scope in future because we have a lot of demand of these optometrists, and most of the optical shops, I don't know, maybe there are 400,000 optical shops in India. Most of them don't have skilled optometrists. So if we have a model where the refraction can be controlled telemedicine in a distant way or in a remote model, I think teleoptometry definitely has a futuristic potential, basically because glasses generate revenues. And so there are some models which are coming up, but definitely some model, teleoptometry is a model which we should try to explore. And patients are now used to sitting at home to get everything, right from food to chicken to everything. So patient also wants to have a eye checkup done at home. So at home eye testing methodologies like IQ is app-based equipment which the patient can buy, I think for less than $50, and then he can get his vision checked and then the refraction and also the power prescribed. So he doesn't have to go to an optical shop. So maybe at home vision testing, which is done by the patient himself. I think that has got some futuristic potential. These mobile phone companies, right from Google, everybody who's trying to work on the artificial intelligence, also are working towards something where patient can himself get his retina checked, like a self-testing of your retina, and then only if you have a problem, you go to an ophthalmologist. So these kind of models definitely have a future. And there are lots of companies that are now coming up with online visual field testing. So you don't have to go to an ophthalmologist to get your vision tested. So you can download an app and then you can do a visual field testing right from home. And so these have reduced the cost of testing. And with the COVID implications where patients are not going to the ophthalmologist, I feel there is a huge potential for online visual field testing. MRF, and there are a few companies that are coming up with these kind of models also. The challenges in these models are always definitely the cost of the equipment. The future depends on how the cost of the equipment is going to be lesser. Basically, because why we are not able to scale our teleophthalmology model is we are now in 275 locations, but still I thought we should be at 3,000 locations, at 30,000 locations, but the cost of a fundus camera, cost of the device hampers it from scaling up. So there is a lot of revolution coming up, innovation coming up in imaging devices. So maybe there are devices that are going to cost less than $50, $100, where you get good anterior segment pictures and good fundus pictures, basically at a very low cost. So you don't have to worry about the cost of the equipment. The future definitely depends on getting very low cost devices, which can actually be given free to even a medical store or to a lab, and then you get those images. That is when teleophthalmology is going to grow to a larger extent. And we have to think about the individual private practitioner. I think teleophthalmology will scale only when it's not being done in institutions alone. The trend now, many ophthalmologists take teleophthalmology as a fashion. So somebody who does teleophthalmology is looked at as somebody trying to do something different or somebody wanting to publish a paper. But teleophthalmology should incorporate into a mainstream ophthalmology practice, even by an individual practitioner, so that it's actually getting him more patients into his clinic, a way of outreach, a way where he can reach out to more patients. That is when the teleophthalmology will definitely reach out to a lot of people. So let's say in 20,000 ophthalmologists in India, maybe if 6,000 of them are able to use some model of teleophthalmology, I think that is when the future and the potential to reach more patients actually happens. So there's a race for artificial intelligence and ophthalmology. All these companies, right from Google to Microsoft to Optos to all these companies have come up with AI, but I still feel the AI cannot work alone. So the AI has to be combined with lower cost devices, with software, access to ophthalmologists, patient acceptance, revenue models, lot of things. So most of the AI companies have still not figured out any revenue models. So AI is the future, but still it's got some time to go. Maybe I feel at least another 5-10 years before actually it comes into mainstream practice. So even Dr. Hunter mentioned about the FDA approval of IDX Retina, I think the diagnostic company which got the FDA approval for artificial intelligence. That's something which also is a milestone determining the future of ophthalmology. The data-driven machine learning, where you have this AI support for OCTs, for fundus pictures, for field analysis, everything. I think that's got a potential. So as I mentioned before, the cameras have to become cheaper if there is, we want to reach to more number of patients. I think future also depends on the equipment. So it's a combination of ophthalmology and then the equipment company, the software company, and everybody. So basically, I think all of us have to combine together. So a little bit about, I will finish in 1 or 2 minutes. I think I'm running late. So I started this around 5 years back, and then we are now present in almost 275 locations and reached out to almost 15 lakh patients. So basically on a very for-profit model. So there's no funding or anything. I received venture capital funding and then reached out to these patients. And it's not enough that only one company should do it. I think every individual ophthalmologist who's sitting here and then who's listening to these talks have to start some form of teleophthalmology. That's when you can really see a future. So this is about how many people have been benefited using our business model. So I would like to finish with my contact details. So if anybody wants to contact me to know how we have been doing this, well, we will be very happy to collaborate with ophthalmologists. And thanks to Teleophthalmology Society for considering us also along with the doyens of ophthalmology in India. Like when I wanted to join ophthalmology, I got a reference of Dr. Natarajan because his close friend said, see, somebody from Tamil Nadu is actually the top ophthalmologist in India, because I had concerns joining ophthalmology because I thought, is ophthalmology a good specialty? So somebody showed me Dr. Natarajan and then he told me that, see, somebody from Tamil Nadu has reached such a great height, and it's been a pleasure to be on a corner with him and talking to him on a platform along with him. I think that's a great honor, and Aravind has been a huge organization. And, happy to be on the same platform. At least thank you for giving me a seat on the corner. Thank you. Thank you, sir.
Thank you, Sendil. And I think the whole idea is to inspire people, and that's why I put Swami Vivekananda. And I think if you have the power, you have the will, you can do it. So that's why we're all here. Yes, thank you, Dr. Rajiv.
I think now Dr. Patnaik has to take over because Dr. Rajiv has to leave. He has left. So now I think that the talks are over. We'll go to the panel discussion. It's over to Dr. Patnaik to moderate this session.
So we are coming to the end of our program, and I'm very happy, and I congratulate all of us actually for this nice launching of the Teleophthalmology Society of India. So coming to the panel discussion, the topic is road ahead for the TOSI, because we have very experienced and distinguished panelists also. So we want to listen from Dr. Babita. So what does he think about the challenges that the public, because most of the challenges that the ophthalmologists are facing are going to face in adopting teleophthalmology, we have listened to during these discussions. And what is, according to your opinion, the challenges for the public to adapt to this new technology? Because most of the public are accustomed to physical one-to-one discussion regarding their health problems.
Yes, thank you, Dr. Patnaik. I think for the public, most likely there would be lack of awareness about, availability of teleophthalmology. Also, I think they would probably doubt the accuracy. But however, I would think in the last, especially because of the pandemic, we've all seen that the public also, I mean, the patients also have resorted to using a lot of teleophthalmology. So many cases of mine, like patients where we've done corneal test suturing, we've not been able to follow up. They've just sent simple pictures of their eye, and I can see that probably it's a loose suture which has now gotten infected. And I've been able to step up antibiotics. These are patients who were treated in Mumbai and then they moved to their villages. And because of lockdown, they could not come back. So they also do understand, like when Dr. Senthil said, like the first approach is where there's a direct patient and ophthalmologist connection. I think that also can work, especially even if they're sending simple pictures, sometimes that can work. Of course, if they have their lenses attached to their iPhones, most people have smartphones now, so that can also work. The second issue, from the ophthalmologist point of view, of course, would be the quality of images. But if you have a center, like most of them, the previous speakers have talked about, where you have a vision center where a basic, examination and imaging is being taken, and that is being relayed to the ophthalmologist, I think that can also allay the concerns for most of the public that yes, good quality images are being seen, a proper consultation is being given. So I would think, in both the approaches, whereas a direct, in fact, we had an opportunity to do both, because we had a technician at the hospital in the height of lockdown also, where the technician would then take images and send it across to us, and direct patient images also. So I think both of that really worked. And as Dr. Hunter also mentioned, I think the third view, use of teleophthalmology, which I really had not thought about. They're taking so much of second opinions from ophthalmologists all over the world, and having a pool of data and minds where we can actually use that for helping our patients. I think that really is going to be wonderful for teleophthalmology moving forward.
Yes, what I got from your discussion is we have to also work on public awareness to adapt to this technology along with ophthalmology. Now, coming to the ophthalmologist point of view, we have three categories of ophthalmologists working: some with solo practice, then some with small institutions, and others are in bigger institutions. Now, things in the bigger institutions are a little different from smaller institutions and solo practice. We have with us Dr. Ashok Nanda, who is running a small institution with 5-6 ophthalmologists working in his place. Now, I am going to ask him what he is thinking about how he can use teleophthalmology model to improve the service delivery by his institution. Dr. Nanda, please.
Thank you, Dr. Patnaik. First of all, I must congratulate Professor Subudhi and Professor Natarajan for forming the society. I'm sure that this is going to actually turn the stones and reach out to people. This is going to the future. That's what I think of. But in my opinion, there are some lacunae which we need to address. The first is, we all know that 75% of ophthalmologists, unfortunately, in India, cater to only 25% of population. So definitely, TOSI plays a great role in reaching out to people. For an institution or for individual practitioner, hub and spoke model, which Dr. Kim has elucidated, is probably not going to be a very, very effective method because of lack of doctors to address those type of practice. Suppose I'm an individual practitioner and I have 5 centers where I have optometrists to take care. I, being a solo practitioner, probably will not be able to give time to address those population. Number one. For a small institution also, that's the problem. In addition to that, the finances and the viability is another concern. The third problem in this thing in Eastern side is that people here come by the name of doctors. They do not come in the name of hospitals, nor unless it's a big institution. So in a ophthalmology medication, how much patients will probably agree to that is something which you have to really look into. So as far as reaching out, it is a win-win situation for everybody. But the acceptance by public is what is to be worked on. The second is a network should be formed, a network in the district whereby all individual practitioners and small institutions, along with the hub, which is a tertiary care center, should be into a single platform. So what happens is, if a patient comes and he is not able to be handled by me, or I being an individual practitioner or a small institution, would have the benefit of taking opinion from the local area. Okay, so in that case, the patient can be treated at one point by 5 doctors from 5 different specialty without the patient having to move around. So that networking should be available. Again, in that, the problem will be like timings. Would every doctor be asked to give specific timings for a teleconsultation? So those are the things which came to my mind, where I think if we are putting it into practice, the role has to be seriously played from each angle: the infrastructure, the finances, and the time. These three has to be well managed. Otherwise, it will again go back to the closed chapter.
So now I request Dr. Kim to respond to Dr. Ashok's concerns.
I'm sorry, I actually missed a few things in Dr. Ashok because of the internet, but I just wanted to talk about the private practice. In one of the instruction courses and earlier sometime in Hyderabad in AIOS, there was a telemedicine instruction course, and I was surprised to see many of the ophthalmologists, especially in North, they are having what they call as vision centers, which means multiple places where they travel to during the week, where the patients are pooled, and actually the doctor goes there, examines the patient, prescribes glasses, and then comes back. If all these could be converted to an ongoing, regular place where they could do a teleconsultation instead of them traveling, it really makes a big difference for them. I mean, this is the way they get patients from those areas for surgery, for whatever, including prescribing glasses. If that could be converted to teleconsultation, one, it's almost available every day, and then they need not travel, and the patients can be referred only as and when needed. So that was a lesson for me to see when many of the doctors were saying they have all these practices that they travel to throughout the week on an ongoing basis.
Yes, sir. The only issue is, as I said, in most of the states, people like to see the doctor face to face. They should accept the doctor advising them over internet. Again, where the doctor is not visible. That is the issue.
Yeah.
That's what we discussed initially regarding public perception, how to change that, and awareness building is what is required. And once they are convinced that they are going to save money out of this and time also, so I think they will adapt to this. Now I want to listen from Dr. Hunter. So what is the Orbis Cybersite model for small institutions to provide tele-ophthalmology service?
Yes, and all of our vision centers are connected. A lot of them can be for education, but also patient consults. A lot of our consults are very high level. So it's not primary eye care, it's usually super subspecialty. So, certainly we have a portfolio to offer peripheral centers. Most of them use the resources for school screening, primary eye health, teaching nurses how to do either ophthalmic care or ophthalmic screening. We don't do a lot of telemedicine in the rural eye centers because we're trying to do peer-to-peer, ophthalmologist to ophthalmologist, super specialist to super specialist, kind of what Dr. Kavita Rao was saying, where, yes, you can look at whether there's a loose stitch or not, but really does this patient, how is DSEC looking? The flap has not stuck for the past 3 days. That's not something that a primary center would do. So I would say in our experience in India, and I certainly, again, would encourage this panel and society to please go to Cybersite and tell me what we're missing. We do have a pretty comprehensive primary eye health training program. That to me is where the eye centers have benefited both, where they can see how to use a torch exam, how to screen a child for strabismus or ptosis, things like that. We don't do a lot of rural teleconsults or AI at this time. We really want to prove the concept when it's ophthalmologist to ophthalmologist. And again, I would encourage you, if you go to Cybersite, if you go to the consultation page, just hit the drop down and hit AI consult. You do have to register, but it's free.
So can I have a few words?
Yes, sir. Yes, sir.
Yeah. So as the discussion is going on, so a small practitioner can become a live member of TOSI and become the teleconsultant. So a particular day, particular time, he can give some time to the small practitioners needing some help. So he can give advice, to read the image and prescribe medicines too. So he can be an asset to the TOSI. So TOSI members can do that.
So before that, let us listen to Dr. Sandeepak. What is his idea about the challenges that a solo practitioner is going to face in using teleophthalmology? Dr. Sandeepak.
Sandeepak, you are muted. Unmute.
Sorry, sir. So the first issue that may come in mind of a solo practitioner is the financial issue and the management, the HR management, because he has to manage the human resource, which is not professional. He has to train. He have to train them and then implement the project successfully. So it is a great challenge. So handholding is a must for a solo practitioner to start this teleophthalmology services. Second issue is, sir, in diagnostic dilemma. If one solo practitioner is practicing alone and without any handholding, then there may various cases may be encountered where he is in diagnostic dilemma. So there also the role of this teleophthalmology come. So if he is attached to some this associations like TOSI or any teleophthalmological organization, so he can get hand-holding and case discussion with the expert in the field who can help him in diagnosis and proper management of the case.
So what I understand, the road ahead for us is for public. We have to have awareness programs as discussed by Dr. Kavita and also shown by Dr. Helen in our slides, that they are doing virtual program for general public. So can Dr. Helen highlight a little bit about your program, that virtual? Dr. Helen. Okay, so we are unable to connect. Now, I think what we should do is we have to prepare models like vision center model, as Dr. Kim has already said, that what will be the expenditure involved in that, so that anyone interested to set up a vision center with tele facilities, we can guide them properly. And the second is diabetic retinopathy screening model also, that we can prepare with offline and online AI. So that will also help to solve a lot, a good number of people. And any other thing anyone can suggest also that we can include in our activity that we are going to pursue in future. Yeah. Any suggestions for any ideas?
Sir,
yes.
I have a suggestion, sir. So this will help in two ways in expansion the work of TOSI, I think. That is, sir, we can incorporate NGOs. We can invite NGOs and small institution to be associated with TOSI as our associates, and TOSI can provide them technical handholding. Handholding like in this sector, that small NGOs or small institutions are in crying need of this CSR donations or venture capitalist funding, but they don't have the channel to establish their project to the CSR donors or the venture capitalists. So there may be TOSI may give handholding to these organizations or startups or this entrepreneurs to project their established MVP in getting CSR fund or this venture capitalist fund in their first round. That can be that can help them as well as the TOSI in enlarge to increase its popularity. I think so.
Yes, to tell just to answer to Dr. Sandeep's question, our membership consists of institutional members and industry members also. So we can index some industry members into our fold TOSI. So they can be asset for us, right? Besides our live membership, right?
Yes.
So what he is suggesting is for providing a platform for ophthalmologists to use telemedicine, teleophthalmology. The second thing is how that can be sustainable. What is his idea is it will involve in business houses and other NGOs and CSR fund, then we can provide a sustainable model. Now opinion from our
Dr. Central had actually planned a group purchase of equipments for dry eye management. Similarly, for TOSI can probably negotiate with companies so that we get teleophthalmology equipments at a cheaper rate. I mean, taking interest of people who would like to establish, and the group purchase would probably come out cheaper.
Yeah. Opinion from our president, sir. And concluding remarks.
Thank you. Actually, I was typing a long mail to Hunter. I think Hunter is there. I just sent the mail. I was enjoying communicating with him right now and reconnecting. So I think I'm glad we formed this Teleophthalmic Society of India, and looks like connecting with the old friends. And Professor He from China is very close, and we both are International Council of Ophthalmology Board of Trustees. So we always sit together and attend the meetings. So many times, actually, I'm amazed by his contribution, making a He University, He Vision Institute, and many. And I think that's in my thing as an ophthalmic university. And I've seen in Arvind website, Dr. Nam also wanted to do a virtual ophthalmic university. But I think, as Dr. Sandeep was saying, everything is finally revolving around money. But that's not a problem. I think you can conceive. And I think, as I put it in my slide, I think, like Swami Vivekananda says, arise, awake, stop not until you reach the goal. And I think our goal is we have Dr. Badrinath, Dr. Venkat Swami, who has mentioned about how we should prevent blindness, particularly to treat the needless blind. So I think that's how I think I want to make sure that we, through teleophthalmology, even the Telemedicine Society mentioned, we should do as much as free. That's the same thing I was writing to Dr. Hunter. So I think all of us are earning, and that's why, as a president, I requested Diabetes Month, November, should be done some free work daily, the 30 days. And I think All India Ophthalmic Society and Teleophthalmic Society and also telemedicine should do that. Because in India, we have a lot of people who need care, and same thing is applicable to South America, Central America, and Africa. So I think this teleophthalmology, we can make a global village, and we can work with the Cybersite, with the He Vision Institute. Dr. Helen has come back, and also the great institutes of India, which is showing way to the world, is Arvind, Shankarnetralaya, LV Prasad, All India Institute, and several others. So I think with this, I'm glad, and thank every speaker, and thank everybody who really worked, especially, anyway, we have a special word of thanks prepared by Dr. Sheila Jung, so I don't want to do her duty. But as a president, and as a founding president, I'm very happy that you chose me. And I'm actually eager to hand over to the president-elect, Dr. Kim, as soon as possible. Because he's also eager to take over from me.
Not before 3 years. That's a long time to go.
Yeah, we'll make it such a big organization and then give it to him.
Yes. So ma'am, it over to you. Dr. Sheila, madam, over to you.
Read the slides, so.
Yeah.
Vote of thanks. by the Teleophthalmology Society of India. Acknowledgements. I would like to thank everyone present virtually today, especially following notable dignitaries, Dr. Hunter, Vice President Orbis, Dr. Ellen Yan, Director, Executive Vice President, Liaoning He Eye Hospital and He University, Dr. Colonel Ashwini Goel, Founder Member and President, Telemedicine Society of India. A special appreciation to Ashwini Sir for his wonderful address. All India Ophthalmic Society of India, I extend a special thank you to the President, Professor Dr. Manipal S. Sachidev, for his excellent speech. A very special thanks to the General Secretary, Professor Dr. Namrata Sharma, for a superb speech. All members of AAS who have made this virtual event feasible. Endopharma background, improving patients' quality of life, enhancing therapies, developing and marketing high-value quality branded pharmacy products for patients in need. We appreciate Endopharma's support of this virtual conference. And a very big thank you to the speakers. Thank all the speakers for their excellent presentation. Dr. Hunter has shared his excellent insights and also he was able to answer many questions. Dr. Ellen Yan has provided valuable observations on community health. I especially thank Professor Dr. S. Nadarajan Sir for his insights on the working of offline AI in diabetic retinopathy. A very warm thanks to Professor B.N.R. Subudhi for the memorable welcome address. I thank Dr. Abhishek Sachidev for his wonderful spirit of comparing. Dr. Kim Sir has impressively covered the vast topic about teleophthalmology in India. Dr. Sendil has shared his observations on the future of teleophthalmology. A special appreciation to Rajiv Raman for his seamless efforts. We had an excellent and informative panel discussion. Thank you, moderators and organizers of the panel discussion. Dr. Patnaik, Dr. Kavita Rao, and Sandeep Ray. As very special thanks to Ashok Nanda.
Thank you.
And again, a very special thank to TSI President, Professor Dr. S. Natarajan, President-elect, Vice President, and all executive members who have contributed to the function. A very special thank to all delegates who have made this conference a success. My warmest thanks to everyone for the support and contribution for the Teleophthalmology Society of India. Thank you.
Especially thank Entered, Mr. Raman is here, Mr. Rahul is there, and Mr. Vivek Tiwari is there. And thank Mr. Kishore Masurkar, the Managing Director, and Nikhil Masurkar, both are great friends. And I think thanks to Raman, thank you very much. Please convey our thanks to Entered because you, me as several positions started all the webinars with you in April 8th, 2020, and we are April 4th, 2021. And I think you have done some hundreds of webinars. Thanks to Entered for promoting education and teleophthalmology. Raman? Raman, can you hear us? Or Vivek? Raman,
Raman is not there.
Anyhow, thanks, Rahul.
Thank you, sir.
So,
thank you, Kavita. Thank you.
So warm applause for the TOSI. So warm applause for the TOSI. So goodbye, everybody. So it's it's a wonderful meeting, and we look forward to meet once again.
Yes.
Maybe in the fortnight.
Kavita, April 4th is also LV Prasad Foundation Day, no?
No, sir. It's in October.
October, okay, fine.
Yes.
You did a program 040404 in 2004.
Okay.
That was handing over charge to Rabi Thomas.
That was different.
Okay.
Right.
Good. Thank you, Abhishek.
Okay, sir, thank you, sir. All the best.
Thank you all.
Thank you, Abhishek.
Thank you all. A nice meeting.
Thank you.
Thank you. Bye. Thank you.
Thank you, Helen.
Bye, Dr. Helen.
I would
Dr.
like to
Helen
say-
will be in touch.
Yeah.